Hello everyone, good afternoon or good morning or good evening to everyone for wherever you're joining us today. My name is Vivian Hanrahan and I am the webinar coordinator with the HRB-TMRN webinar series. And we'd like to welcome you all today to the webinar. We're delighted to welcome Dr. Victoria Shepherd, who is presenting today on clinical trials involving adults who lack capacity to consent and challenges and innovations for the inclusion of an underserved population. So just a bit of background, first of all, on Victoria. So she is a research fellow at the Centre of Trial Research at Cardiff University, where she leads a research programme exploring the ethical and methodological challenges around the inclusion of adults lacking capacity to consent to trials. Her work has included exploring decision-making about research participation on behalf of adults who lack capacity and the development of a novel decision support intervention for family members acting as research proxies. She's also led the development of a core outcome set for interventions to enhance proxy consent decisions, and her current project, Consult, includes a SWOT to evaluate the decision support intervention in a range of clinical trials and settings. She has a clinical background in critical care nursing, and in addition to her research exploring complex consent pathways, she co-leads the inclusivity theme of the MRC-NIHR-TMRP, that will make sense to some people, conduct working group. So that's the Trial Methodology Research Partnership Conduct Working Group, and is member of the NHS REC and has a research portfolio in care homes. So before I hand over to our speaker today, I just want to remind you that we will be recording today's webinar and it will be available on our website shortly after the session. And also at the end of the presentation, we're going to have a Q&A session. So if you can think of any questions throughout the presentation, please put them in the Q&A box there at the bottom of your screen, and I can put those to Victoria at the end. So without further ado, I'll hand you over to Victoria.
Thank you very much, Vivian, for the very kind introduction. So what I'd like to do for the next probably just a bit over half an hour is to talk about how adults lacking capacity are underserved in research, explore some of the barriers to conducting trials involving adults lacking capacity, and then share some of the work going on to help address some of those challenges and think about what the areas might be for some future work. So you'll all be very familiar with the idea that we need to increase the underserved populations in research. And it's the kind of view that focusing on the number of people taking part in trials is no longer enough, but we need to think more about who is taking part. But adults lacking capacity have been identified as one of the underserved populations. But of course, the definition of underserved depends very much on the context and the population and the condition being studied. But in reality, this group is probably made up of lots of different populations, which includes older people who've been described as living in a knowledge shadow, who's being almost systematically excluded from research. And other examples might include people with a limb disability who are also underrepresented in research. And then, for example, people with hip fractures who, despite often having associated cognitive impairment, are often excluded or ignored from trials. And for these people, capacity kind of acts as a kind of gatekeeper to research. So despite them often having the highest and most complex care needs, so arguably most in need of research, this quote here from Arkinson's UK says that it's important not to exclude people who lack capacity from taking part in research, in the same way they shouldn't be excluded from accessing services and medical treatment. But we know that these sorts of trials are quite complex, and it's often that complexity that leads to them being excluded. So this is a quote from a participant in my current qualitative study exploring the barriers and facilitators to research that includes or aims to include adults lacking capacity. And this is a quote from a member of a research team who described their decision not to include people who lack capacity in research being the path of least resistance. They knew it would be difficult and thought it was just too much. They described how, as a researcher, it feels insurmountable, like a black box of horrendousness that I dare not go. They felt there was very little guidance. It feels if you get this wrong, you'll be illegal, and the ethics police will come for you or something. It's scary, and it shouldn't be scary. So why is addressing this black box of horrendousness so important? Well, over 2 million people in the UK have significantly impaired decision making, and the prevalence varies depending on the settings and populations, but in some acute medical settings it might be around 40 to 50%, rising to about 70% of older people living in care homes, and then 90% or more of critical care patients. And of course, this is something that could affect all populations, because loss of capacity could be temporary or may fluctuate over time, for example, in some mental health conditions and in dementia. So we really need to be considering capacity to a kind of greater or lesser extent in all studies. But as research is essential in order to improve care, excluding people from research means that there's less evidence base for their care compared to other groups, leading to what has been termed evidence-biased care. And of course, it also raises much broader concepts of equality and inclusivity due to what is essentially a disability-related exclusion. But there are particular ethical considerations in trials that involve adults with impaired capacity, and these often centre around the alternative decision makers, so the other people that are involved. And the terms used for those vary, but consultees, legal representatives, and a range of other terms in different legal jurisdictions. But these ethical and more broader issues are what leads to adults who lack capacity consent being generally underrepresented in research. And as with so many things, COVID-19 has shone a real spotlight on this. So COVID has disproportionately affected older people, as you'll be aware, and dementia is in itself also a risk factor for contracting COVID-19, requiring hospitalisation, and also leading to death. And older people living in care homes are at particularly high risk. But also people with learning disabilities who were up to 6 times more likely to die from COVID during the first wave than people without a learning disability. But when it comes to being included in trials, even prior to COVID-19, we know that 90% of RCTs were designed in such a way as to exclude people with a learning disability. And a review of COVID-19 trials found that half excluded older people, and they were excluded from all the vaccine trials that were included in that review. And the large primary care platform trial of COVID-19 therapeutics in the UK, which included care home residents, initially excluded those who lack capacity, which, as we know, is about 70%, probably more. And this has led to calls to address some of these barriers to participation and to address the eligibility criteria that unjustifiably exclude them. But we know that COVID-19 trials in critically ill patients, of course, the majority of whom will lack capacity due to hypoxia or having been sedated and ventilated, has been a real success story. So there are also lessons to learn about how these trials have been designed and delivered, which enabled the inclusion of people who lack capacity. So what are some of the challenges to including adults lacking capacity in trials? Well, these could be broadly grouped into systemic, structural, and methodological factors. So the systemic factors might include things like the complexities of the many legal frameworks involved, including across the UK and Ireland, and the challenges of getting ethical approval, but also the widespread paternalistic attitudes that kind of see the need to protect these groups that are considered vulnerable from the perceived harms of research. Some of the structurally determined factors might include things like the resource-intensive nature of these trials, the lack of appropriate research infrastructure to support their inclusion, and compared to the huge amount of work being done to support informed consent for people who give their own consent to take part in research, there's a lack of interventions to inform and support these alternative decision makers, so the people acting as consultees and legal representatives. Some of the methodological issues might include things like the overly restrictive eligibility criteria, and also the challenges of developing and evaluating interventions for these populations. So I'm just going to talk through a little more detail about some of these. So in terms of the systemic factors, the complex jigsaw really of legal frameworks that cover both CTIMPs and non-CTIMPs in different parts of the UK and Ireland, and of course across the EU and internationally, is very complex, and that's especially so for emergency research where there are quite significant differences. And this can be especially challenging when a trial has sites in several of these different areas. But when we're conducting studies with these populations, kind of anecdotally, we also encounter quite a lot of misunderstanding or a lack of understanding about the legal frameworks. So in order to kind of get a sense of this, we conducted an online survey of health and social care professionals to explore how much they knew about the legislation governing research involving adults lacking capacity. And we used kind of 5 different scenarios to kind of tease out some of their knowledge a little bit. We chose health and social care professionals because they're often involved in either sharing information about research, actually recruiting participants, or sometimes acting as a gatekeeper for those in their care taking part in research. The survey included 127, and they were a mixture of medical, nursing, allied health professionals, and social care practitioners, 63% of whom described themselves as being research active, and these were things like being a chief investigator or a research nurse or practitioner. And what we found was that actually there was very low levels of knowledge, even in those who were chief investigators and research nurses, across all the different scenarios. So some of them were community-based, some of them hospital-based in different conditions. And in fact, only 4% provided responses which were considered to be concordant with the law in all scenarios. We found that there was a number of misunderstandings about where the authority for making decisions about taking part in research should lie. So often thinking it should always be the clinical team who decides rather than being a family member. And things like thinking that that person should have to hold a lasting power of attorney in order to be able to make those decisions. But it also revealed a deeper and perhaps more worrying issue about their attitudes towards the inclusion of people with impaired capacity in research. So a number of participants stated that people who lack capacity should never be included in research, and some voiced concerns that only an appointed judge should have the authority to decide, and only when it would be determined to be in their best interest to take part. Another example is how the kind of paternalistic approach, which positions health and social care professionals as the kind of gatekeepers to research, also is often reported for members of research ethics committees or committees as a whole. And we know that the challenges of getting ethical approval for these types of studies is a common theme that's emerging in the interviews I'm currently conducting. But it's also been well illustrated in this article, which describes the challenges of gaining a favourable opinion for a trial. And this trial was developing and evaluating a dementia support worker intervention that was based in primary care. The research team had developed a person-centred and flexible recruitment pathway in consultation with their public involvement group, but they still described their journey through the ethics process of being challenging. They said the first panel we applied to gave an unfavourable opinion. It was advised that we should initially only recruit people who had capacity in our study. And the PPI group expressed incomprehension at this stage, saying it felt unethical to exclude them, and pointing out that how do you ever change things for people without capacity if you don't include them in research? And the researchers noted that there's a need for improving consistency of interpretation and advice from ethics panels so that hard to reach groups are actually enabled to take part, in this case, in intervention development research. And then thinking about the structural barriers. So one example is the more resource and intensive nature of these trials compared to other trials. We often can't recruit through the more traditional methods, such as people responding to invitations to take part. And we know that staff involved in delivering these trials need to have more skills and time required, because they need to initially identify potential participants, but then also that kind of process of assessing capacity and building a relationship with them and providing tailored information takes longer. But then they might also then need to move on to identify suitable consultees or legal representatives and then inform them and get agreement from them. So we know that trials involving adults lacking capacity are likely to be more costly and lengthy than trials that solely recruit people with capacity to consent. And that was illustrated by this recent trial, which included both participants with and without capacity, and they explored some of the time and costs involved. They said that securing personal consultees made the recruitment process more time-consuming, often requiring multiple visits and more phone calls. and that it wasn't always clear that someone lacked capacity when an initial telephone contact to arrange a home visit was made. So that kind of unexpected component as well. But they recommend that people factor this into study planning when designing these type of studies. One of the things we also know is that despite a huge amount of focus on improving the content of participant information sheets, when we think how much work goes on to tailoring that information and ensuring it's well understood, it was quite surprising that no previous work had been done on information sheets provided to consultees and representatives, even though arguably they probably need more complex information because they need to understand not just about the study itself, but also about their role in being involved in making decisions. And we know that if consultees aren't properly informed, it could lead to them making poorly informed decisions, or sometimes just declining to be involved at all because they're uncertain about what it is they're being asked to do. So we looked at the information given to consultees and legal representatives about their role, and this included both personal consultees, so family members, as well as professionals acting as consultees and legal representatives. So we looked at 30 studies in England and Wales across different populations. So that included populations where perhaps there was a sudden loss of capacity, something like an acute stroke, or where a more progressive loss of capacity over time, such as dementia, or trials that involve people who may have had perhaps lifelong impaired decision-making, so perhaps with people with learning disabilities. And we kind of include those. We thought the kind of context would be important. We analysed content in 5 different categories, including why they were being approached and what information they were given about the basis for their decision. And we concluded that actually, despite undergoing ethical review, so these were all studies that were up and running or had already been concluded, but actually study documents often lacked the kind of essential information that would have been needed to make an informed decision. Quite a lot of them incorrectly used terminology, so referred to consent when it was a consultee giving advice, and a whole range of other terms that perhaps wouldn't be recognisable. And a lot of them conflated the kind of professionals' clinical roles and representation roles. So, for example, a consent form for a professional legal representative, some of them might have the appearance of a referral letter rather than a consent form, often requiring only one signature, not a counter signature from a researcher. And some didn't make it clear in the information sheets that a professional was not being asked to determine eligibility, which of course is the role of the recruiting clinician, but actually to provide advice or consent about the person's wishes. And of course that can be quite challenging to do, and that might be one reason why they were structured that way. And then, as well as the information provided to consultees and legal representatives, what about the process of decision making as well? So again, when we think how much attention goes into improving informed consent processes for people giving their own consent, it's really striking that even though these decisions are probably more complex, there's been almost no research in this area. So these quotes are from the decision study, in which we explored how personal consultees and legal representatives had made decisions about research on behalf of a family member. So these came from interviews with 17 family members who had acted as a consultee or legal representative, and it included people who had both agreed to participation on the person's behalf and those who had declined. They were primarily in relation to people living with dementia, but there were also some more acute conditions. And what we found from those interviews was that decision-making is actually a very complex process with these kind of interwoven layers of decision-making, which could be quite straightforward for some people, but actually could be quite problematic for some too. And as shown here, some described it as being actually quite a tough decision. We found that family members balanced quite a number of different factors when deciding about research participation, including what the person's wishes and values would be, but within the kind of specific context of the study, and as well as the practicalities of being involved. So many of these people were often carers for the person they represented as well. And we found that they then used these factors to construct a decision that they thought was authentic to the person they cared for. So rather than being a kind of accurate prediction of what they thought the person would have wanted, which of course wouldn't have been possible, they came up with a decision that they thought kind of reflected those values and wishes. But many of them worried about whether it was the right decision, and they feared making a wrong decision, which for many was linked to there being a poor outcome for the person taking part in the study. And families thought they might benefit from more guidance and support to make a more informed decision, as they described perhaps a slightly different sort of information sheet or something to help you understand your role, and actually prompting people to think it isn't about me, it's about them and what they would like. And then when we think about some of the methodological barriers, so one example is the overly restrictive criteria for inclusion in a trial. If you think how often you see must be able to provide informed consent as an eligibility criteria, but it might be perhaps a less obvious exclusion around an arbitrary age cutoff, or excluding people with comorbidities or communication disorders, or some trials will use a cognitive screening tool with a cutoff point, something like a mini mental state. And what we know is that exclusion of people with cognitive impairment is widespread. So even in areas where there may be quite high levels of cognitive impairment in the clinical population. And some examples I've shown here, which include older people, people with stroke, learning disabilities, neurological research, rehabilitation interventions after hip fracture, but there are also trials in other areas such as emergency research for things like trauma and critical care. But they also encounter significant challenges around informed consent and the inclusion criteria, which impacts on the populations that can actually be included in these trials. And this might be around the consent model used, for example, or sometimes where the trial doesn't fit the criteria for emergency research, but has very tight recruitment windows, which leave very little time to identify and contact families. And of course, all this raises real questions about the generalizability of these trials. And to get a sense of the current position, we wanted to get a snapshot of how adults lacking capacity are included in UK clinical trials, where alternative decision makers are involved. We did a search of the ISRC-TN registry for UK clinical trials, and we looked specifically in conditions that would be commonly associated with cognitive impairment. We didn't include trials that used a deferred consent model or a waiver in those kind of emergency settings, because we were particularly interested in trials that involve consultees and representatives in that decision making. And we then got details about the participants actually included and their capacity status from either published data or directly from the trial teams. So of the 80 clinical trials that have been completed in the previous 3 years, we identified 15 which had included adults who lack capacity to consent. Data about participants' capacity status is rarely reported, but even when we contacted the trial teams, this data weren't available for 5 of the trials. But where capacity data was reported, we found quite a range. So between 5 to 100% of participants lacked capacity to consent. And when you get down to those very small numbers, it means that even in trials that are designed to include adults who lack capacity to consent, the proportion and numbers of participants lacking capacity actually being recruited are perhaps worryingly small in some of those trials. Trials, as you might expect, mostly use personal consultees or legal representatives, but surprisingly, nearly 40% of participants had required a professional to act as their consultee or legal representative, which was actually much higher than we expected. And so when we're designing these sort of trials and thinking about the kind of consent models and the approach we might use, we probably need to take quite careful account of this. And of course, there are much broader methodological barriers too. So even when the trial is designed to actually include adults lacking capacity, they can be methodologically very challenging to conduct. Things like developing a common protocol for use in different jurisdictions. So if you have a trial in England and Wales, as well as other areas like Scotland, you'll have to have parallel ethical approval processes, so multiple IRAS numbers, different versions of consent documents, and where people are recruited using different recruitment pathways, of course, that needs to be taken into account in the analysis as well. And of course, cognitive impairment not just impacts on capacity to consent, but also on ability to engage with the intervention and to respond to it. So some of the challenges include the difficulties of developing or perhaps adapting complex interventions and then evaluating those interventions. And this may be further complicated by the challenges of a lack of validated outcome measures for some of these trials. So, for example, there are a few mental health measures for people with more severe and profound intellectual disabilities. And also the feasibility of using existing self-reported outcomes, things like quality of life measures, so EQ5D, which of course might be challenging in some of these groups, such as care home residents. And while there's been a lot of work going on to establish the reliability of proxy reported versions of some of these, there's still a very limited range of appropriate and validated measures in these populations. And that inevitably will limit the ability to evaluate the effectiveness and cost effectiveness of these interventions. And of course, there may be similar challenges around ensuring intervention fidelity where self-report may be limited. But also retention and loss to follow-up may be different in these populations where perhaps capacity is lost or regained during a study, and that affects the ability to consent to continue and whether to use the person's data or not. There also might be quite high mortality rates. So for example, people living in a care home, the average length of time living in a care home is perhaps around 12 to 18 months. And of course, there's a growing number of trials being delivered remotely, and there are additional challenges, particularly around identifying and recruiting people with impaired capacity remotely. Things like, can you use e-consent? How do you assess capacity remotely? Or when you're using postal recruitment or postal follow-up, how do you know whether people have capacity when they're returning questionnaires? So what are some of the interventions that we might be looking at to deliver, given the kind of extent of some of these barriers? Kind of where do we start, really? Well, we know that this is a priority area and the need to improve the inclusion of underserved groups has been widely recognised. So you'll be familiar with the Priority 1 work to identify the highest priority areas for recruitment research. And that includes a question about the best approaches to ensure that underserved or vulnerable groups are able to participate. And of course, many of you will be familiar with the NHR Include work, which is looking at how to improve the inclusion of underserved groups in research, and they've developed a roadmap to help identify particular checkpoints for when decisions are made during the design of a trial and delivery of a trial that might affect the inclusivity of that. And that's throughout the kind of life cycle of the trial, from setting the research priorities through to dissemination. But of course, there are additional challenges unique to when we're looking to include populations with impaired capacity. How do we include them in public involvement and research priority setting? And what's the best way of disseminating trial results to those groups as well? So given the sort of complexity of some of these issues, we kind of thought the first step is to recognise the complexity of these challenges. And those, of course, range from those kind of ethical concerns and paternalistic attitude, right through to how we fit trials into existing research infrastructures and that kind of patchwork or jigsaw of laws I've described. So that led me to kind of draw on a complex systems approach and developed a socio-ecological model which can then incorporate some of those multiple components and how they might interact with each other. So at that kind of individual level, we might think about how the person themselves is informed and supported, then the alternative decision makers, the research community, and that includes people designing and delivering trials, up to the research governance processes, and then that kind of policy and legal framework perspective. And while there are a number of areas or potentially modifiable factors, our initial target for interventions are at kind of that individual, interpersonal and community levels. So we know that one of the challenges is identifying someone who's willing and able to make a decision about trial participation. And as our decision study and other studies have shown, even once identified, families can find being involved in those decisions quite overwhelming, with many experiencing some degree of burden. And as I've mentioned, despite the number of interventions being developed to improve informed consent processes, very few have been developed to improve decision-making for adults lacking capacity. So we've kind of concluded that intervention is needed to address the challenges experienced by consultees and legal representatives, and to provide them with some decision support. So if you're not familiar with decision aids, these are increasingly being used to help patients making decisions about treatment choices. They're often used for preference-sensitive decisions where there isn't any clear choice, and it informs the person about the choice, outlines what each involves and respective risks and benefits. It kind of goes beyond that kind of informedness and actually helps people make more values-based decisions to think about what option might best align with their preferences. There have been a small number of decision aids developed for trial participation decisions, mostly about specific oncology trials, breast cancer and prostate cancer. And they show some improvement in key decision outcomes, so things like values clarification and decision conflict. But the first decision aids have also been developed for non-oncology trials. But despite that kind of difficulty around how we make decisions for other people versus ourselves, there aren't any decision aids for alternative decision makers, so consultees and legal representatives. So I've developed a decision support intervention, which was developed in line with the process developed by Katie Gillies and Marion Campbell from Aberdeen for the development and evaluation of decision aids for trial participation decisions. And of course, this is adapted from the MRC guidance, so you'll recognise some of those stages from development through right round through to evaluation, implementation. I won't go into too much detail here about the development process, but essentially this is a theoretically and evidence-informed intervention which was developed during that decision study I've already mentioned, and to help develop the content and develop a prototype decision aid. It's now undergone initial acceptability and kind of alpha testing in a follow-up study last year called Decision 2, and that used cognitive testing and then made refinements to the intervention. And of course, it's been developed in conjunction with the support of a lay advisory group who have advised throughout on the content, format and design, and will continue to do so. The next stage is to explore the effectiveness through a feasibility study and a SWOT as part of the Consult project that I'll explain a bit more about in a moment, and it will also focus on implementation. So the decision support booklet itself is a colourful 12-page A5 booklet, and it's intended to be generic rather than trial specific, and it will be provided to family members alongside the consultee or legal representative information sheet. And it's got sections explaining why they're being approached and what they're being asked to do, and kind of orientates them towards thinking that it's not really about what they would want to do, but it's about the person they're representing. It also includes a values clarification exercise to help explore what's involved in the study and help them to elicit what the wishes and preferences of the person they represent would be. So thinking about the kind of different factors involved. They're also encouraged to write down any questions or where they would like more information, which of course all of this could then form the basis for discussion with the research team. And there's an accompanying educational or training component for the clinician or research practitioner or whoever is actually approaching the family member and providing the booklet. And as I say, the plan is to evaluate as part of a new project called Consult. So Consult is a 4-year project to evaluate the intervention as well as addressing perhaps some of the other barriers and identifying areas for future innovations. It's conducted in 3 stages. So as I've already mentioned, a qualitative study called Consult Enable, in which I've been interviewing researchers, so chief investigators, trial managers, research nurses, to explore some of the barriers and facilitators to the design and delivery of trials involving adults lacking capacity, and also getting a sense of their views about the decision support intervention and how we could conduct a SWOT. I've just finished recruitment from this and data collection and analysis is now started. The second stage will be a feasibility study to help inform the randomised SWOT, which will be the 3rd stage of the project. And this will help to address and also I'll talk about that a bit more in a second, but also to help kind of address the knowledge gap that we've already identified. Another part of the Consult project is a new website that draws together information and resources to help support researchers and healthcare professionals involving people with impaired capacity consent. And again, I'll say a bit more about this in just a moment. So thinking of the SWOT, the aim is to explore the effectiveness of decision aid. It'll be provided alongside study information, and then that will be compared to people receiving just the standard study information alone. Randomization could ideally be at the individual level, but could be clustered at the level of recruiter or site. And I say that's something I'm exploring in those interviews. In terms of the outcomes, so the core outcomes have been identified in the core outcome set called Consider. And a new measure has been developed, which is a combined scale for proxy-informed consent decisions called Concord, which is currently under development. And the main kind of domains of interest are around that kind of informed and understanding, but also about values clarity, preparation for decision-making, satisfaction with decision-making. In terms of the cost, the project's been designed so that costs would be provided to host trials to cover any of the SWOT-related research activity. And in terms of timescales, at the moment, we're developing the eligibility criteria for host trials. Again, that will be informed by the current study before registering the SWOT. And we're looking at starting the feasibility at the end of this year and then progressing to the SWOT, all being well, the middle of next year. In terms of the online resource that's also being developed, there are kind of practical resources that are grouped under headings around designing inclusive study, research ethics, communication and capacity, and there's some downloadable summaries, but also pages with links to more academic publications and training resources. And you can also review the resources sort of mapped out along the research pathway. And while the website's intended to be inclusive of all populations and groups where there may be issues around capacity and consent, for the legal framework aspects, there's a particular focus on England and Wales, but many of the resources are applicable to all, including things around how to design more accessible trials. And the plan is to add some case studies a bit further down the line to kind of tease out how this has worked in practice. And any feedback is very welcome indeed, including if there are any publications or resources you know of that could be included but aren't. So please do let me know if that's the case. And then one of the other things being designed as well, I'm sure you're very well aware of the Include work and the ethnicity framework that's hosted on the TrialForge website. And that's intended to be a practical tool to help those kind of early design stages around how we can design trials to be more inclusive. So we've also developed, or in the process of developing, a new tool following that same kind of ethnicity framework structure, but this is a tool to help design trials to be inclusive of people with impaired capacity to consent. So again, quite a practical tool to help at that kind of early design stage. Like the ethnicity framework, it has the 4 key questions that trial teams should be asking around who should be involved in the trial and how you can facilitate their inclusion. And then with worksheets to help kind of expand answering those key questions. And for this framework, there are some accompanying resources, which are a summary of legal frameworks and signposting to more resources to help in that kind of design process. And this is currently under development. We're in the process of consulting some key stakeholders prior to user testing. And then lastly, we start to think about where some of the other areas for potential innovations might be, again, going back to that kind of model of the different levels that you might want to target. So starting at the individual level, these might include developing more cognitively accessible participant information about trials. At the moment, we probably set that threshold quite high by having these long and quite complex participant information sheets. But actually, if we can design them to be more accessible, cognitively accessible, and support people to make their own decisions about trials. And perhaps also exploring, thinking about how we can help people to prospectively plan for research in the event that capacity is lost. So for example, people diagnosed with something like dementia, how they can express their future wishes and preferences. We also need to address these kind of overly restrictive eligibility criteria and to be more carefully designing consent models to ensure that people are not just recruited, but also retained, for example, if they lose capacity during a trial. There's also a new group being formed in the Trial Conduct Working Group to explore alternate and complex consent pathways, and that's led by Julia Wade in Bristol. That's another component of work going on as well. And of course, we need to have better systems in place to support both families who act as consultees and legal representatives, but we need to think about having more evidence-based information that we provide to them. So in the same way that we have done for consent forms and participant information sheets for giving our own consent, we need to explore what consultees and legal representatives think are the important pieces of information to contain in information we give to them. We probably need better guidance and training for everyone involved in both design, conduct and delivery of these sorts of trials. But we also need to engage with funders to ensure that there's better funding available that better reflects the kind of complexity and resource intensive nature of these trials. We also need to think about improving governance and the legal frameworks to better balance protection and inclusivity, thinking about perhaps having more streamlined approaches across the different jurisdictions, and most importantly, more consistent review by research ethics committees. But I think fundamentally, we also need a sea change in attitude in recognising that we need to protect these underserved populations through research and not on research. So I will stop there, but please do get in contact at any point, as I'm very happy to answer any questions. And there's the details of the website there, and I can also be contacted through the website too. Thank you very much.
Brilliant. Thank you very much. That was excellent, Victoria. Really, I think your idea there with the online resource is excellent, because it's just great to have something at your fingertips. So that's really good. So just to remind everyone, please send in your questions through the Q&A box, and I can ask them then to Victoria for you. So I'll probably kick off here now first with a question from Susan. So she says, such an important talk, great work. We have experienced a real challenge, including patients who do have cognitive capacity but lack other types of capacity or have low health literacy in a trial setting, disadvantaged communities, etc. Are you aware of any resources for translating the complexity of consent around data management and GDPR for these types of participants?
Thank you, and that's a really good question. And these are challenges that we obviously encounter in trials, including people without cognitive impairment and communication disorders. And then when you include the additional complexities, it does get very difficult. And the short answer is there aren't really any resources at the moment. But what I hope is that the work going on with people who don't have cognitive impairments, but have perhaps additional health literacy or language factors to consider, that perhaps some of that work can then extend to these populations who have cognitive impairment as well. So I think we're probably a little bit further behind that curve, but hopefully as that work goes on, then we can extend it to these groups. And it kind of feels that's how a lot of this work is going, that, we first of all improve things for people who can give capacity and then kind of extend that to these populations as well. But yeah, a really, really important issue to try and address.
Yeah, and another question here then from Emily, who says she really enjoyed your excellent, clear presentation. She wants to ask a question around reassessing capacity to consent throughout the trial. So she says, we have experienced a lot of difficulty with the ethics question about what happens if someone loses capacity during the trial. They haven't been happy that once consented, they will remain in, akin to an ACP decision. Do you have any insights onto that, please?
Yeah, again, a very, very good question. And so essentially, certainly, obviously, I don't know what area Emily is referring to, but certainly in England and Wales, the Mental Capacity Act is very clear that there is a presumption that someone has capacity unless concerns are demonstrated otherwise. So I think in terms of ethics committee, if you are clear that if someone has capacity to give their consent up front, that you presume that they have that capacity throughout the trial, unless there are concerns. And that's often the tricky thing. How do you know there might be concerns, particularly where people are returning a postal questionnaire, for example. But there may be other things that you can introduce as well. So perhaps an accompanying phone call, perhaps depending on the nature of the trial, being in contact with other care providers, so GPs, in the same way that you might do it prior to sending out questionnaires to check that that person hasn't died, for example, during the trial. So there may be other ways that you can get additional information. But I think certainly being clear that you are following the Mental Capacity Act's presumption of capacity. Of course, there are populations where perhaps longitudinal, perhaps a dementia trial, something like that, where you might expect there to be cognitive changes. Again, you might want to introduce other processes, so visits, phone calls, or perhaps someone providing the details of a study partner up front, who, if you are unable to contact the participant and you have concerns that their capacity status may have changed, that there's someone else you can get in contact with as well.
Mm-hmm. And leading on from that, then another follow-on question from Joseph was saying, great talk, by the way. As capacity is presumed intact unless proven, can we deal with this, or have to prove in advance before recruitment? Sorry, does that make sense? Maybe I didn't read that properly. As capacity is presumed intact unless proven. Oh, sorry. What can we do? Maybe it's what can we do with this? Or have to prove in advance before recruitment?
Yeah, so that possibly relates to the previous question. So again, that there is this presumption that someone has capacity unless you have concerns, and then a mental capacity assessment would be needed. Again, this is particularly referring to England and Wales, different in different regions, depending on the legislation. And what you can include, of course, is if you're concerned that someone may lose capacity during the trial, is you can include that in the information sheet and in the consent form up front. So someone can indicate that if they lose capacity during the trial, they're happy to remain in the study, should they lose capacity.
Yeah.
But for CTIMPs, consent survives loss of capacity, so that consent would endure throughout a trial. For non-CTIMPs, that's not the case. If someone loses capacity during the trial, you will need to involve either a consultee at some point, or consider that they won't be able to remain in the study. But certainly informing people up front what your intentions are and having their agreement is certainly a strong signal then that they would want to stay in the study if they lose capacity.
Yeah, absolutely. Okay, so moving on then to another question we have. From the Consult Enable qualitative study you're currently running, what are some of the barriers and facilitators to involving adults lacking capacity that are being identified by participants?
Yeah, and these have been really fascinating. So I've just finished, so I've done 26 interviews. I'd say they range from chief investigators, trial managers, senior trial managers, research nurses and practitioners. So kind of across the broad range of people designing and delivering these kind of trials. And depending on their kind of role and the context of the trial, there are certainly some very common themes coming out. So a lack of consistency, or perhaps just poor advice from Research Ethics Committee. It's certainly what a lot of people are talking about, because people are worried about getting it wrong. So when designing trials, certainly when delivering trials, people get very worried. So think about that quote about someone talking about the ethics police coming after them. You know, this is what kind of people are concerned about. But people have very much spoken about the importance of being able to access expertise in this kind of area. And that might be within the research team or perhaps externally drawing on other expertise. But it's very much ad hoc. So people might have someone within the research team, they might not, but often speak about what a difference it could make if they perhaps had an expert down the corridor, they could go and knock on their door and ask questions. People are also talking about the need for perhaps more training, things to help them translate those kind of principles into practice, because that's often one of the challenges, is that these are not black or white situations. And it's those kind of complexities and the kind of way everyday practice of designing and delivering these trials, it's really where the challenges are.
Yeah, absolutely. Another question here from Rachel. She is asking about remote consent. She said, we use postal invitation mailouts to consent older adults to trials. We're keen to include those who may have conditions that mean they lack capacity to consent. Do you have any examples of how this is done in trials where there's no clinical face-to-face opportunity?
Yeah, again, this is something that's coming up a little bit in the interviews as well. And again, it depends on how the trial is designed, what the intervention is, and how it's being delivered, that may help a little bit. But certainly posting something out and then getting a reply back, or not getting a reply back, can be where it's quite challenging. And again, there may be opportunities if it's through a GP practice, that the GP practice may be able to identify someone who is a family carer, perhaps registered as a carer on their database, that you could involve in sending information out. You know, sometimes you can encourage people to have a phone call. So if you have any questions, to ring us. But it definitely, these kind of remote trials, and of course we're seeing that increasingly the case, are throwing up new complexities.
Yeah. Okay. We've had a post in from Marion just referring to some NIHR funded resources for accessibilities for consent. And she's sent it to us panelists. What I might do is put it into the chat so everyone can see it and share it. It's from asphasiatrials.org. I don't know if you're familiar with that. That's that group, Victoria, but I'll post it there. I'll repost it for everyone to see. Another question then is, you mentioned about doing a SWOT. So I was just wondering, what might some of the challenges of conducting a SWOT in decision-making interventions be?
Yeah, and you know, I'm sure everyone will know that you know, designing a SWOT is complex at the best of times, but trying to sort of unpick what the best kind of trials will be. So think about this kind of eligibility criteria, because obviously we're going to need trials that have relatively high proportion of people lacking capacity. The consultees are needed. And what is coming out of the interviews is that people are describing are actually probably more important to look at trials where the decision is perhaps more weighty. So that might be where the intervention perhaps is a higher risk or a higher burden, or there's more involved in taking part in that trial compared to something that is perhaps quite straightforward, where a low risk, not particularly intrusive intervention. But a lot of the challenges around about integrating it into existing trial processes. So because the decision support booklet would need to accompany the consultee or representative information sheet, how that is shared will have a big part in whether it's the best kind of trial design to have the SWOT embedded in. So ones that are just posted out, for example, and there's no contact directly with consultees, may or may not be the best approach going forward. But most importantly, these are quite challenging trials at the best of times. So the SWOT very needs to take into account that we don't want to increase the complexity of that trial. So think about the randomization process and how we're going to collect data, and even to give consent for the SWOT component. It's very much going to need to be integrated into the existing trial processes.
Yeah, I'd be interested to see how you get on, just on a personal level. I'm interested in this. Okay, I think that rounds up all our questions now for today. So I just want to turn everyone's attention to the diary, kind of just finish up. This is our last webinar before the summer break, but on the 16th of June, there is another webinar by our colleagues at Cochrane in Sweden, I believe, and they're having a webinar on clinical trials reporting and registration. And then after the summer, we'll be starting back our webinar series on the 8th of September with a webinar from our colleagues in Western University in Ontario, and they're presenting on pragmatic trials. So that will be interesting there. And then also, just to make a note of the date for October, is the 7th annual Trials Methodology Symposium. And this time the HRB-TMRN are joining with the UK, with the TMRP, to have the symposium on the future of clinical trials, people, projects, purpose and place. So registration for that will open shortly on our website, and that's going to be on the 4th, 5th and 6th of October. So just to remind everyone, today's webinar will be available shortly on our website, and you'll be able to look back on it then. And Victoria has kindly offered to share her slides. If anyone wants them, just drop us an email, we'll send them on to you. And just to say thank you very much, Victoria. It was really fascinating. I really enjoyed today's webinar. I think it's really added to our knowledge on informed consent, and really thinking about this group of the underserved population. You know, it's very current, and I think it's something that we all definitely need to turn our attention to. So thank you very much for joining us, everyone, and thank you, Victoria, especially.
Thank you. Thank you.
Okay, bye-bye.